Welcome to the overview of the capabilities-based approach to public health preparedness.
My name is Christine Cosmos. I'm the Division Director for the Division of State and Local Readiness at CDC within the Office of Public Health Preparedness and Response. And in this unit, we're going to take a little bit of a closer look at the capabilities-based approach.
One of the nation's key preparedness challenges has been determining appropriate state and local public health preparedness priorities. To assist state and local public health departments in their strategic planning, CDC implemented a systematic process to define a set of public health preparedness capabilities. This process incorporated a comprehensive review of evidence-informed documents and relative preparedness literature, along with subject matter expertise gathered from across the federal government and the state and local practice community. The resulting body of work, Public Health Preparedness Capabilities, National Standards for State and Local Planning, outlines a capabilities-based approach that will assist state and local planners to identify gaps in preparedness and develop plans for both building and sustaining their capabilities. The approach also provides structure and focus for CDC's Public Health Emergency Preparedness, or PHEP, cooperative agreement. It clarifies expectations for PHEP-funded states, localities, territories, and freely associated states, and helps CDC measure progress toward achieving public health preparedness. Introduction to the Public Health Preparedness Capabilities discussed how and why the capabilities were developed, and details some of the benefits to this capabilities-based approach. In this overview, we will provide background information on the development of the approach, discuss how the public health preparedness capabilities are structured, and, using one capability as an example, demonstrate how its component parts relate to one another. The capabilities-based approach identifies 15 public health preparedness capabilities, each of which represents an essential and critical aspect of preparedness. Here they are in alphabetical order. These capabilities can be used broadly to prepare for any type of public health emergency and hazard, whether a result of man-made threats, biological agents, natural disasters, environmental exposures, chemical and radiological incidents, or explosions. Let's take a closer look at the overall structure of state and local public health capabilities, including the capability definition, associated functions, tasks and resource elements, and performance measures. The capability definition defines the capability as it applies to state, local, tribal, and territorial public health. Each capability is composed of 3 to 5 functions. Functions are critical elements that need to occur in order to achieve the capability. Each function, in turn, is supported by both preparedness and response tasks. These tasks detail the kinds of actions that need to occur to complete the function. They can be observed and evaluated during a response or under exercise conditions. Performance measures defined by CDC may be associated with some of the functions. These measures monitor the extent to which jurisdictions are able to demonstrate their performance on specific preparedness and response capabilities. Finally, to be able to do any or all functions and tasks, one needs resources. These are what a jurisdiction should have or have access to in order to successfully perform a function and the associated tasks. There are 3 types of resource elements: planning, skills and training, and equipment and technology. Planning. These include having standard operating procedures and emergency operations plans in place. They may include memoranda of understanding with partner agencies, or language which describes a public health agency's legal authority and role under a variety of emergency conditions. Skills and training. These refer to the baseline competencies and skills necessary for personnel and teams to competently deliver a capability. Equipment and technology. These specify what kinds of equipment, including information technology, jurisdictions should have or have access to in order to carry out a capability. Among the resource elements, CDC has designated some as priority resource elements, which should be considered to be the most critical and a minimum standard for state and local preparedness. Jurisdictions are encouraged to consider having the other recommended resource elements in place. Let's apply the capabilities-based approach in the context of a public health preparedness capability using emergency operations coordination as an example. Emergency operations coordination is defined as the ability to direct and support an event or incident with public health or medical implications by establishing a standardized, scalable system of oversight, organization, and supervision consistent with jurisdictional standards and practices and with the National Incident Management System, or NIMS. In other words, effective and orderly management of a response to an incident with public health implications must be systematic, sensitive, and responsive to changing conditions, and consistent with procedures used by other emergency management agencies. There are 5 functions that need to occur in order to achieve this capability, and, for each function, various tasks should be carried out to operationalize it. In addition, the capability includes several performance measures and priority resource elements. We're going to talk about 3 of these functions in order to get a sense of the types of activities that should be considered to perform each of them. Next, we'll take a closer look at one of the functions to discuss the performance measures and some of the priority resource elements that support it. Function 1 is conduct a preliminary assessment to determine the need for public activation, which involves 3 tasks.
For whatever emergency that arises, a multi-car crash on the interstate, a chlorine leak at Metro Chemical, we'll need to determine the public health impact of the event that's unfolding.
We'll work with local public safety and other local response partners to decide our role in the response. Are we going to be a lead or supporting organization?
We'll need to decide at what level the Public Health Incident Command System should be activated in order to carry out our role.
Function 2 is activate public health emergency operations, which involves 6 tasks.
Who has the authority to activate the EOC?
Who is trained and available to take on Incident Command lead roles over an extended period? We'll need continuous staffing for as long as emergency operations are activated.
Do we have potential emergency operations center locations identified? We may be sharing a site with other agencies.
Functions 3 and 4 involve developing the incident response strategy, managing it, and maintaining it. Let's jump to Function 5, demobilize and evaluate public health emergency operations, which involves 5 tasks.
Getting back to normal has its own challenges. How will we gradually step down the response, and how will we provide for the needs of our public health responders?
We'll need to pack away all the supplies such as cots, screens, and equipment, making sure they're in good condition and in the right locations for use next time. We'll also need to inventory supplies like gloves and masks for replenishing.
And here's a big question. What systems are in place to assure that we can learn from the response experience and make improvements for the future?
While it is not mandatory that every jurisdiction perform every task that was discussed, as we can see, many tasks would be performed to carry out the function. Let's take a closer look at the performance measure and resource elements that are associated with Function 2, activating public health emergency operations. There is one performance measure associated with Function 2. It is staff assembly, the time it takes for pre-identified staff covering activated public health agency incident management lead roles or equivalent lead roles to report for immediate duty. Assembly can occur at a physical location, for example, the EOC, a virtual location, for example, a web-based interface such as WebEOC, or a combination of both. While all awardees report their best demonstration of a staff assembly, this measure has special importance for the 50 states as it has been designated a priority goal by the U.S. Department of Health and Human Services and the Office of Management and Budget. The priority goal specifies a target of 60 minutes for state public health agencies to convene a team of trained staff that can make decisions about appropriate response and interaction with partners.
We need to fill Incident Command lead roles quickly, so we'll need to have accurate contact lists and redundant means of making contact. If we can notify key staff by cell phone, email, landline, and pagers, we have a better chance of quickly making contact than if we just call cell phones.
The quicker we notify, the quicker we can assemble.
Function 2 has at least one of each of 3 types of resource elements described earlier: planning, skills and training, and equipment and technology. Having written standard operating procedures for the management, operation, and staffing of the Emergency Operations Center is one of 5 planning resource elements and is a priority resource element. Thus, at a minimum, these written procedures should be in place. There is one resource element under skills and training for this function, and it too is a priority resource element. It is, staff involved in incident response should be competent in the incident command and emergency management responsibilities that they may be called upon to fulfill in an emergency. There are 3 resource elements under equipment and technology. They are, have or have access to backup equipment in the event of system failure or power loss in the Public Health Emergency Operations Center, communications equipment to allow information to be transmitted inside and outside the EOC, and information technology equipment sufficient to meet the event or incident objectives. While none of the equipment and technology resource elements is a priority resource element, all of them can help build and maintain the ability to perform the function of activating public health emergency operations. Public health preparedness capabilities, national standards for state and local planning, includes a public health preparedness capabilities planning model, which offers a series of suggested activities for preparedness planning. As a first step, jurisdictions are encouraged to self-assess their ability to address the priority planning resource elements of each capability, followed by an assessment of their ability to demonstrate the functions and tasks within each capability. Jurisdictions may follow different strategies to operationalize them, or they may address the capabilities in different order, informed by their own risk assessments, forms of government, and population characteristics. Preparing for public health emergencies requires continual and coordinated efforts involving every level of government, the private sector, non-governmental organizations, and individuals. Public health preparedness capabilities, national standards for state and local planning, are designed to accelerate state and local preparedness planning and ultimately assure safer, more resilient, and better prepared communities. We now conclude this overview of the capabilities-based approach to public health preparedness. For more information, visit the Office of Preparedness and Response website at www.cdc.gov/PHPR. Thank you for your time, your attention, and for all that you do on behalf of our communities and our country.